Hello, this is Fernando Mesancha. This is another real-life HoLEP case showing an en bloc technique, and I will try to explain again the subtleties of this technique, and I hope you can pick up some tricks. This man had a relatively large prostate. I don't remember the exact size. But I decided that entering the bladder was going to cause a lot of traction in the sphincter because it was a big middle lobe. And so I chose to start by doing the apical release from the beginning without forcing the entry. Often when you try to force the entry, you will cause a 12 o'clock split in the urethra. And that's a bad start for a procedure that wants to preserve continence as the primary concern. Here is the delimitation of the sphincter from the apex. I found there was a little bit of mucosal up there, mucosal fold. So I decided to cut it as well. I didn't think that was sphincteric, and here I'm cutting these fibers that you find at 4 o'clock, something like that. When you deepen a little bit there, you know that if you do a little bit of lateral movement of the scope while you dissect this plane, you know that that won't hurt the sphincter because you already detached it at that level. So of course I don't push laterally too hard. I don't want to go and damage the sphincter laterally. So here again, I'm doing the same, cutting these fibers at 4 o'clock. In this case, it would be 7, 8 o'clock. And then, of course, if you go to the floor of the side of the verumontanum, then usually you can find your way towards the proper plane, the real plane between adenoma and capsule. Sometimes there is some doubt. And then you can do a little bit of mechanical push like that to find the proper plane, to make sure that you are in the right plane. Okay, so here in this operation, the idea is that you're going to try a lot of things. Now this is interesting. This is some material coming out of a small abscess, I think, which is quite common in BPH patients. But as I was saying, many times we're going to try things you don't naturally know where the plane is. There's no signs to tell you where's the proper plane. But of course, we will try sometimes to challenge the plane we are using, so that sometimes we will check if there is a plane deeper than where we are, and sometimes we will have to correct. But the idea is, if you do that without forcing too much, without risking too much, then it becomes a safe thing. Not all the prostates show you a beautiful plane. Sometimes it's inflammatory. In this case, we saw some pus coming out of a cavity, and so often the plane is inflammatory. This is okay. This is the best kind of plane you can find, I think. Although you sometimes find it in certain areas and not in other areas. Okay, so this was the development of the posterior plane. I'm checking here if there's any bleeder, because I thought there could be some bleeding going on, some bleeder going on that I could probably stop, but often it is the mucosa that bleeds and I don't bother there. Here you can see the contour of the sphincter, and I put the fiber at 12 o'clock to try to do the early apical release. So initially the prostate is quite fixed to the capsule, so there's very little mobility, there's very little space to get where you want to get. And of course we don't want to force the sphincter. It's like trying to remove this tissue, detach it from the capsule through a keyhole, through a little hole, a little diameter. So it's very important to mobilize the adenoma strategically so that we can liberate the apex without damaging the sphincter, without stretching the sphincter too much. So here what I'm doing is to liberate the posterior apex. So instead of trying to go all the way up, I initially release the posterior apical tissue here from the capsule, because you see this was attached to this here, but now it's open, so we have a little bit better access. So what I am doing is I'm following a series of steps. I'm following a strategy. Here you see I'm seeing that we have to cut a little bit horizontally here initially, and I don't mind doing that because that will try to keep the battlefield a little bit inside, a little bit proximal, and further and further far away from the sphincter. Of course, cutting horizontally means that we open a little bit of access to get more and more anterior each time, but it doesn't necessarily mean that we're going to leave adenoma in place. So I'm just cutting. Initially, this direction is vertical almost, and then when you get close to where the sphincter is, you go more horizontal, like that. You see, that's a change direction, trying to follow the plane. So here, 12 o'clock, sometimes there's fibrous tissue that needs to be cut, similar to what we found when we cut the frenulum of the verimontanum to connect the posterior plane. So here, as you can see, there is a progressive approach to the anterior part, and also very, very careful. All right, so don't despair. Be patient. Make progressive improvements in the situation, so that things get easier and easier. We will liberate the attachments of the sphincter with the apical tissue, and then we will try to go all the way up to remove the adenoma at the apex. I don't want to leave anything there. I don't think it's necessary, and I think it might compromise the future of the patient if you leave anterior apical tissue. So here again, I'm cutting on the adenoma a little bit, because when I deepen this white line in that direction, cutting into the adenoma, I gain some access. I cut some of the fibers that are sticking together the adenoma and the apex. And then, of course, I try to go all the way to the capsule to find what is the proper plane. So most of these incisions are going to be removed when we enucleate the adenoma. And here I'm doing as I did in the other side, trying to mobilize a little bit the apex posteriorly. So this dissection would go probably from the 6 o'clock that we had already done towards 3 o'clock in this side and towards 9 o'clock. And then, of course, you have to go distal to check. You don't want to continue dissecting upwards there, because if you do that, you're going to stretch the sphincter. You're going to, cut the mucosa there, just at that level. So here, I'm going to continue trying to follow the path I marked with the white line, and very carefully, I don't mind cutting a little bit on the adenoma at the beginning, because that will give me access, and then I will look for the proper plane. Here, I usually look at the fibers of the capsule on the external aspect, the lateral aspect, the right side of the screen, to try to understand the direction of these fibers, and that's going to show me the direction of the plane. But again, I return backwards, and I withdraw the scope a little bit to be able to see what's happening at the apex. I don't want to continue the dissection of the plane if I'm going to be stretching these fibers that I'm cutting now. So cut horizontally below the sphincter. It is more vertical. And this way, we're going to work our way to connect the 2 ascending dissection lines at 12 o'clock. So here, you see it's very, very careful, slowly. If you have trouble and you end up cutting horizontally a little bit into the adenoma, and then of course you connect with the other side, you can always check at the end, the apex, and remove the tissue of the apex. But our most important consideration, I think, it's to try to prevent early stress incontinence that we used to see before when we did a classical dissection as described originally with this 3-lobe technique, where one would dissect the plane without looking, without care. I think for the sphincter's mucosa, of course you will open the plane, but you will probably rip off, you will cut the attachments. And here we're starting to see the light. You see that ascending from one of the lines and looking at the apical part, we can connect to the other side. So let's do it carefully and progressively, trying to make sure that we don't leave, as I said, tissue anteriorly. So this would be a better plane, but I'm not taking it towards the midline until I'm sure that the distal fibers have been cut. So here I can get closer and closer towards 12 o'clock, but of course being very careful and making sure that at some stage we will go back to check if there is any other fiber to cut. But you have to work on your dissection lines. We want to have a good line that we can recognize. We don't want to have 4 or 5. That was the instrument that was dislodged for a moment. As I say, you see here I'm trying to work to construct a line of dissection that will connect the anterior plane with the lateral plane, trying to follow all the way up. But of course, we'll see how I don't continue forcing the 12 o'clock region. Of course, I will go back and check. Check if there's any tissue up there. And before I continue the dissection at that level towards 12 o'clock, I'll go out to check. You see there's another nodule here. Of course, we want to remove all the nodules, no matter how close they are to the sphincter. You don't want to leave a nodule there. You might want to leave it for the end, if you consider that you're taking a risk or you're not comfortable in doing this dissection at the apical level. But here you see I'm trying to construct this anterior line of dissection, trying to liberate all the adenomatous tissue, and again carefully check if there are some fibers that might be attached to the sphincter there. Of course, if we are in the white region, we know that we are not in the mucosa. The mucosa is very close. There you saw the contour of the sphincter. We're working a little bit close to that region, but with a lot of care. Of course, when we use the pulse modulated lasers, like this is the Lumenis 120 watt MOSES laser at settings of 2 joules and 50 hertz. And we have the advantage that cutting is enhanced, so very useful to cut this fibrous 12 o'clock attachment. And of course, coagulation is enhanced, which means that we can concentrate mostly on the dissection and the strategy, and we don't have to concentrate so much on keeping a good hemostasis. So that's the moment, I think, when the connection is done. Now the sphincter or the apical liberation has been completed. Now I have to work to try to build a uniform line of dissection anteriorly. So improve the connection and make sure that no tissue is left behind at that level. There we are. Again, checking very slowly. There's no rush. And I tell you, it's been, for this patient, 15 minutes to dissect the apical tissue, but then the procedure is going to move very fast afterwards. So spend your time, take your time, construct a nice anterior line, and then make sure that it connects with the lateral line and that the lateral lines connect to the posterior line, so you have a circumferential line that you can follow. Here, with the wonderful pulse-modulated Moses effect laser here, we are progressing now very fast because the dissection effect is going to come with very good first pass hemostasis that will allow us to move very fast. Of course, we're going to find some individual vessel at some stage in the operation, sometimes more, sometimes less. This is trying to connect the lines, you see, trying to make sure that we don't go very deep anteriorly and we forget about the lateral and the posterior. We want to progress uniformly from the apex towards the bladder neck. Of course, as I said at the beginning, we have to try. If you find that your plane is going too deep, then you will have to correct, and then you have to adjust your targeting, and instead of firing where you were firing, you will have to fire a little bit more medial. If, on the other hand, we find that it seems that we have left some tissue attached to the capsule, then we have to go back, we have to take it out, dig it out. All right, so this is now approaching the 12 o'clock region. There are many vessels here, so I will spend a little bit of time trying to control them. When you don't see the vessel very well because of the blood, you can try to get to the area and do the helicopter. The helicopter is a rotational movement of the tip of the fiber to see if you can stop the bleeder at some stage, or you can try to separate a little bit from the bleeding so that you can see where it is. Most often, it's not about the ability of the laser to coagulate the vessel, but your ability to see where the vessel is bleeding and how to target the laser to coagulate it. In extreme cases, if it gets very difficult, you have to put a resectoscope inside, and often with a loop you can control these vessels. I do it sometimes, so it's not a sin. It's not a problem either. You have to have the resectoscope on the table, ready in case you need it. It's still a useful instrument. And there, for example, I saw a little bit deep plane, so I'm correcting. The important aspect is that you manipulate your fiber and your instrument in a way that everything you do is safe. You don't go too deep, you don't stick the fiber against the tissue so that it could deepen too much. Sometimes I do a little bit of contact, but what I'm trying to say is if you are relatively careful, if you use the energy carefully, and you gain some confidence, you can then progress and do HoLEP in a very safe way. Here you can see the excellent double effect of dissecting the plane. Here, for example, we found two slightly different depths of dissection. When this happens, you just have to connect both depths, and there's no big deal. Don't get confused, don't get stressed. It's just a little technical correction that you have to do. As I was saying, this here you can see how you can dissect the plane, and at the same time you get the benefit of very nice first pass hemostasis. You can see how the tissue gets white in contact with the energy, so you dissect and coagulate at the same time. It's a wonderful feature that allows us to work really, really fast, so we can do large glands in a relatively short time, operative time, and with the benefit of a very, very minimal blood loss and difficulty. seeing well during the procedure it's a great thing. That's the entry in the bladder at 12 o'clock. There you can see how now the dissection progresses towards the side. It's very nice to have this beautiful landmark of the line of dissection that tells you where you are working, and of course you have to be able to anticipate the circumferential anatomy of the prostate. So here in the last part of the operation, typically the fiber has to get closer to the adenoma. So you could, instead of firing at the line of dissection, most of the times you're going to target the laser a little bit closer to the adenoma. And that's because if you do that, most of the energy is going to be absorbed by the adenoma. And there will be very little energy going to the capsule, maybe just to coagulate, but not to cut or deepen, in an area where the capsule might be relatively thin. So this is now reaching the bladder neck laterally, working calmly, working systematically. You see that most of the time the pedal is activated, so there is some dissection going on. And even when I'm not doing anything really crazy or really fast, the operation is progressing very nicely. It's now 21 minutes into the operation. You see that we are approaching the bladder neck posteriorly. So we are nearing completion of the procedure. So now we enter the bladder. You see, so we didn't enter the bladder at the beginning. And this is the posterior line. And notice how the fiber is staying anteriorly, staying close to the adenoma. I don't want to cut there. I want to cut up there, right? Because that will disrupt the fibers that are fixing the adenoma to the capsule without penetrating in the capsule. You have to be careful, concentrate not only on the targeting, but also on the distance, what distance you have to keep from the tip of the fiber to the tissue to get the desired effect of dissecting the plane and getting proper hemostasis without penetrating in the capsule. You see, this is all a progressive effort to liberate more and more the adenoma, to gain the mobility you need in order to reach certain areas. Here we're progressing laterally and approaching the bladder neck area. My fiber is keeping in a cranial position very close to the adenoma. Most of the times the presence of the scope below the adenoma is putting some tension. I'm not doing any pressure, I just want to see the line of dissection in the middle of the screen. So when I position, that's checking for the UO. So when I'm positioning my, my scope to watch the line, here I'm protecting the UO, just making sure that the incision and the level of dissection is a little bit medial, so we don't go back to the UO and we don't damage it. And here, again, the fiber is keeping very close to the adenoma, very, very close. As I was saying, the presence of the scope sometimes is generating some tension in the tissue, and there is some tenting effect. You're pulling when you push the adenoma upwards. You're pulling fibers of the capsule, and then if you cut there, you're going to cut the capsule. So what you want to do is to keep the fiber to target very close to the adenoma, so you don't deepen. Even often we have to correct when you see that the plane is a little bit thin, so you have to correct. Keep firing upwards. You see, it will look as if some tissue is staying, but it's usually not adenomatous tissue. It's just capsular tissue that you're leaving behind. And this is a very, very careful, again, liberation of the posterior aspect to try to approach the bladder neck. Usually this plane changes direction very fast. So you are dissecting a horizontal plane, and then suddenly it becomes almost like a right angle. It becomes very vertical as you approach the bladder neck posteriorly. So you have to be careful and fire always inside or medial or in the side of the adenoma when you target the line of dissection. Of course, this is an adjustment that you have to do every second. So every second of the operation, you're wondering, where do I fire? And you have to be careful that way. That's the other UO, so I'm trying to mark and cut a little bit medially so that we get away from it. There's some middle lobe, so often the middle lobe sits on the trigone. I could get very close to where the UOs are. So here again, now I'm trying to push, you see that lobe, the left lobe of the patient, a little bit into the bladder, and that gives me better access in this side. That's a great trick. I'm not trying to push the whole adenoma because there's still a lot of attachments. And often if you force the adenoma into the bladder, if you want to flip it into the bladder and you push it very hard, you might disrupt the capsule here. You can sometimes open the capsule if you push too hard when the adenoma hasn't been detached nearly completely from that region. So just a little push will open the space for you to enter. And then again, always try to correct if you think that you're going a little bit deep. Keep the fiber close to the adenoma to avoid deepening the plane. And then if you think that the 6 o'clock attachment is small enough so that if we push the adenoma into the bladder, it won't break anything, then you can try to work your flipping of the adenoma here. And if it doesn't flip, don't stop, don't continue pushing. Just check that there is no other attachment that it's limiting the mobility. Usually the free adenoma should go into the bladder quite easily. So if it doesn't, you have to wonder why. And check. It's almost completely gone, but there's some attachment deep there. You see, that's why it doesn't want to go in the bladder. So one of the nice things of having good hemostasis is that you can see what you're doing, and then of course you can continue with the liberation. Here I'm trying to be strategic, targeting the tissues so I can lift the adenoma and I can detach the middle lobe completely while looking after the UOs and complete the enucleation. In this case, it's been now almost 29 minutes, so in half an hour we finished the dissection of this relatively large prostate, and then of course we will secure the hemostasis so that we can do a nice morcellation. See, nowadays most of these operations take under 1 hour. There you can see there is some retrotrigonal growth of this adenoma. So sometimes the change in the plane direction when you're doing the posterior is not 90 degrees, it's probably less, meaning that you not only have to go upwards, but also sometimes it's a very tricky dissection. So here, again, bladder neck, the mucosa can bleed sometimes significantly. I don't really worry too much about that site. This is the sphincter area, a little bit. We can see a small 12 o'clock split in the mucosa, but it's a very good preservation of the mucosa circumferentially. So the patient was perfectly continent the following day when we removed the catheter. and he went home. Again, if you, in this phase, I call it the trimming and coagulation phase. If you see that there's some tissue that looks adenomatous to you, you can go in and check. Often it's not a big deal, but it's incredible how when you see this big cavity, you think that a small nodule is not going to matter, but these cavities collapse over time and they become rather small cavities, and maybe a nodule that is not looking obstructive in this moment could look obstructive or could be obstructive later on with this, when the capsule collapses and gets smaller. So I like to be as thorough as possible, and of course I don't worry for a millimetric little bit of tissue that is hanging there, but I want to check. Sometimes you see there's no harm in going back and checking if you might have left some nodule to make sure that you do a good job. And of course we check the hemostasis because it's really very nice when you can get clear urine postoperatively. Patients are very happy and everybody's happy. So take your time. That's again the sphincter, looks pretty good. And once you see that there is clear visibility and you check that there are no bleeders, some people turn off the irrigation to see if there's any bleeder, because you reduce the pressure in the fossa, and then maybe you will see more bleeders than usual. So that's all, I think, correct. It's something that sometimes I do, not every time, but when I'm happy with the hemostasis, then I proceed to morcellation. You see that the setting changes. If you use the same setting for hemostasis, you have to be very careful to keep a distance that will not disrupt the plane. I have another setting in the second pedal, and that is, I think, 1 joule and 35-40 hertz. It's a much softer deposition of energy that is not aggressive. So if you're firing on a plane that is already gone a little bit deep, you don't want to use a lot of blasting energy there. That might open the capsule a little bit more, but you want to use a soft form of energy like this, you see, that doesn't complicate things. I think that this disruptive nature, the explosive nature of HoLEP might sometimes break the vessels without coagulating them right away. And then, of course, these vessels initially do not bleed because there is some form of spasm in the vessel. And then when you go back after some minutes, you see that the vessel has started bleeding. So that's why you have to check and recheck. Although with pulse modulation and MOSES, we have really improved the hemostasis, and this hemostasis time has been reduced in a big way. You know that with MOSES, there's some groups now doing ambulatory surgery. So the recommendation is to do the enucleation, do the hemostasis, do the morcellation, and then go back inside with the laser to complete the hemostasis. So this is something I almost never do. But if I had to do ambulatory surgery, we cannot do ambulatory because our patients are operated in the evening. That was the deeper region there, you see. It's no problem if you correct, of course, if you follow that plane, that way to the outside of the capsule, then of course there will be trouble. But you see, when you go a little bit deep, you just correct your plane. You don't let it get worse. In this patient, we removed the catheter the next morning. There's no need to keep the catheter for several days, or I think they are so deobstructed after HoLEP that the urine preferentially goes out, rather than going anywhere else. Of course, there's a big perforation, might be trouble, but these small areas of thinning of the capsule are of no consequence, clinical consequence at least. So that's the mucosa of the bladder. Sometimes at the edge there are some bleeders and you don't easily see them unless you look for them. So this is what I am typically looking for at the end before morcellation. Okay, so this is 5 minutes of hemostasis time. And we are now changing the instrument to be able to start with the morcellation phase. It's important to have a good team that can help you in the operating room, that allow you to do a fast change of instruments, change the camera, prepare the morcellation. It's important to have the morcellator ready, I think, when the operation is starting, so you don't want to come to this moment and have to wait to set it up. And that is the morcellation position. We have discussed this many times. You have to keep the blade a little bit inside so that you can see the adenoma anteriorly, the blade in the middle of the image posteriorly, and then two black triangles lateral to the blade. That will tell you that you are far away from the bladder. If these black triangles get pink, then you know that you're getting close to the bladder and there might be a risk for an accident. Here I'm not using a second irrigation line. I know that everybody recommends it and many surgeons use it. I try to be very conscious of balance between entry in the bladder and outflow. So with this equipment, when I see that the morcellation is working well, you see that you don't see very much the opening in the morcellator blade tip, and the fact that suction is keeping the tissue close to that opening makes sure that there's not so much water coming out. So I can trust, in my experience, that the bladder is still full, there's not much water coming out. If morcellation is inefficient and you start seeing the blade, the mouth of the blade more often, and you keep sucking water out, of course the bladder can collapse and then there might be a risk for the bladder. So if morcellation is not efficient, I try to stop, refill the bladder, palpate suprapubically that the bladder is full before I continue. See, sometimes the adenomas have very hard nodules inside, very hard fibromas that are difficult to morcellate. The morcellator will chew preferentially the soft tissue, and at the end of morcellation you're left with these beach balls that are very difficult to chew. Not everybody has these. Also, sometimes the morcellator is working in optimal condition with very good vacuum, very good suction, and the blade is sharp, and you can morcellate even the tough pieces. But some other times, for some reason, it becomes very difficult, and then you have to go in with a resectoscope maybe and cut these nodules into smaller pieces. Or if it's a big nodule, sometimes you can make cuts in the surface, and when you go in with a morcellator again, then it's easier to morcellate. But often I use the resectoscope when I find these nodules. This morcellation is going well. It takes a little bit of time because the amount of tissue is significant, And of course, morcellating a big adenoma takes longer. But with this Piranha system, we are measuring usually about an average of 10 or 11 grams per minute, unless, when morcellation is very inefficient. But this is a good case, I think. You see, it's a very static morcellation. You don't move from the safety position where you are working. And as long as the morcellation is happening and everything is good, you don't need to change your strategy too much. Often I try to reduce the adenomatous tissue into a smaller piece, and then I try to suck it and bring it into the fossa. Because if you do that, then the adenoma is going to be still mobile. It will move from side to side, which is what you want. But it would be clashing a little bit with the walls of the fossa or the walls of the bladder neck, I think it's happening now a little bit. And then it doesn't go away too far. Often when you swallow the tissue, when the blade has to swallow the tissue that is cutting, there might be a blockage. And if there's a blockage, then there's no vacuum, there's no aspiration in the tip of the blade, and then there's a disengagement of the adenoma. The adenoma floats away. And if you are in the bladder, that can happen when morcellation is inefficient. That can happen more often. And if you are in the fossa, when the piece has been reduced significantly, then that can happen, but the adenoma doesn't go very far, and then the suction will catch it again, so that morcellation is a little bit more efficient. So with each morcellation, and every surgeon has different tips and tricks, but I think it's preferable to have these black triangles on the side of the blade than only seeing. I mean, if you keep the tip of the morcellator very close to the lens, then you will only see white tissue, and you lose awareness of where you are in relation to the bladder or the bladder neck or the prostatic fossa. There we are. The morcellation is progressing really well. It's now 42 minutes in the operation. So it must have been a big prostate. Sometimes we weight the tissue as we finish the procedure, but often we're just working, and we have to move to the next patient, and we don't have a lot of time for these things outside a study or something like that. Often the pathologist tells us how much the tissue weighted when he received it after fixation with formalin, but we record many videos, and often I forget who is the patient we operated, and we it's difficult to know the exact size. To see in biggish glands like this, probably, by the way it looks, it's probably more than 100 grams of adenoma. Well, you have to be patient and relaxed, waiting to complete morcellation. You have to be very present in the moment, in the operation. Don't lose concentration, because everything has gone very well, but things could change very fast if you're not careful. And it's important that your team is also involved. I tell my nurses, if I forget to open the inflow, or maybe the bladder is full enough, I don't open the inflow, I start morcellation. You have to check that I have opened the inflow, because if you do that, then you're a super nurse, and when I do this mistake, you will save the day, because we are doomed to make mistakes at some stage, working in this long list. And it's important to build a safe environment where you can work, and both the nurse that is scribed by you and helping you, and the circulating nurse and the anesthetist and everybody understands the procedure and can help you participate. Everybody has to be present in the operating room. Often the attention drifts away with conversations, and it's a routine operation, and it's important that you keep your focus during morcellation and during the whole operation, actually, until it finalizes happily. So as the piece gets smaller, the suction is more effective, bringing it against the blades, and it's easier to move from side to side. There's less inertia inside the water. And but of course, some other things happen. Sometimes the basket gets full of tissue, and the vacuum is a little bit less because of this with the piranha morcellator, and then you have to change the bucket of tissue and empty the water and deposit. So sometimes we have to stop and start and wait for 2 or 3 minutes until your team can do the change. And in that case, I don't leave the water open. I close it. I want to over distend the bladder. Sometimes I wait until it fills completely again. I feel it with my hand on the pubis, and this is a little bit of a blockage. You see that the suction didn't work. You see, it's not sucking tissue. So we pressed a button that releases the vacuum a little bit on the machine. But you see, the morcellation is not so efficient anymore. So I think I told my team to change the basket of tissue, which was quite full at the time. Although it seems that some of the pieces want to be morcellated. So be careful when this happens, because you can suck too much water out, and then the bladder will collapse. So I think I just told them, please change the instruments, and you'll see that after the change, morcellation efficiency will come back, will return to normal. Hemostasis is holding and visibility is holding. I always say that there is a window of opportunity for morcellation if you keep the bladder distended for enough time, and if you distend the fossa, there will be some blood accumulation and the visibility will drop, and maybe you have to go back to do hemostasis again before continuing, which is a great loss of time. There we are. So everything was changed, and look at the renewed efficiency of morcellation. I like to keep the blade often just above the bladder neck. It's a very safe position. Here you see how if you have the piece or the blade too close to the lens, then you have very little information of where you are. Of course, I am quite immobile. I fix the blade in that position, but I don't enjoy morcellating like this for a long time. You should see a little bit. That's why I moved a little bit away. Of course, with experience, you can, tolerate some of this, but for people who are beginning, I think you should stress the safety measures. I know where I am. I'm probably 1 or 2 centimeters above the bladder neck, away from the bladder. But as I said, in your case, when you're learning, if you're learning, maybe you're already very experienced and you can do a very safe morcellation without so much care, so much attention to the safety details. But in general, every surgeon has to know what is his experience and what is the level of risk he can take safely. Let's put it that way. We shouldn't take any risks, but the truth is, when you operate a lot, sometimes you do take a little bit of risk. And this is the end of the procedure. I hope you enjoyed it. This was 49-50 minutes for a quite large prostate. I cannot tell you how large. But I hope you enjoyed the dissection of the apex and the dissection of the bladder neck area and how this looks in the real life. See you around, and I think the video is finishing.